In this PowerPoint, we'll be talking about decision making at the end of life, which has been pretty much codified in the Virginia Healthcare Decisions Act, but there are several nuances that are important that we appreciate in this conversation. The first is the determinative question of whether or not a patient has the capacity to consent. This is the statutory definition that you can probably relate to. It certainly talks about whether or not a patient is capable of understanding and acting upon what the benefits and risk of a proposed treatment is. And it also protects those who may have dysphagia or other communication disorders who are mentally competent. And the distinction between capacity and competency is important. For example, here is the statute that deals with competency. And competency is the kind of global determination made by a judge as to whether or not a patient can manage their own affairs and whether or not a guardian or a conservator should be appointed to protect that individual. You'll see that that is different than the situation where a one-off decision is being contemplated under the Healthcare Decisions Act. A guardian does not have to be appointed for a patient who may lack capacity under the Healthcare Decisions Act. So it's a little confusing in that sense. So let's talk about end-of-life decision making. We'll talk about the informed consent for the competent patient. We'll talk about the incompetent patient. So let's jump into the Virginia Healthcare Decisions Act. The first topic we'll take up is advanced directives. The second is surrogate decision making, where there is no advanced directive or the patient lacks capacity. We'll talk about a DD&R order. And last, we'll talk about using excessive doses of pain medications for treatment of patients at the end of life. For advanced directives, usually the preferred route, of course, is that we have a nice written one from which we can operate. However, there are also the ability to create an oral advanced directive by a patient at the end of their life. A written advance directive can be made at any time. Obviously, many people do it when they do their estate planning, but it can be done before or after a diagnosis of a terminal condition. It can be made in the hospital, out of the hospital, wherever an individual would like to make that directive. It is, the old terminology was a durable power of attorney. That is the kind of the old terminology, even though there is still many wills and estate lawyers who use that. The more current and under the Healthcare Decisions Act terminology that's used is advance directive. It requires that the patient sign the advance directive in the presence of two other witnesses. Those may be anybody, such as a spouse. It can be employees, it can be blood relatives. And I would suggest that, in fact, it is important that a patient include their family, maybe not as particularly as witnesses to the document, but certainly include them in the conversation. And so one way of doing that might be to get them to sign the document themselves, because it is often difficult for family members to be making these difficult decisions when they are under stress, and having them aware of and involved in a patient's advance directive is certainly a prudent course. It is up to the patient to notify the physician by providing that to his attending physician at his routine outpatient care. However, as medicine is practiced often these days, the primary care physician who sees the patient as an outpatient often is not involved in hospital care. And to that end, it's important that the patient or family provides the advance directive to the hospital. And you will note that there is an obligation for the hospital to inquire as to whether or not there is an advance directive. Virginia has also provided for a web-based registry of advance directives so as to hopefully make them more available to healthcare providers at the time of need. The advance directive can be kind of anything that one wants it to be. It can be a very detailed uh, narrative of I want A, but I don't want B. I'll take C, but I don't want D, sort of thing. And of course, the irony is that often what was contemplated by the patient is not what actually becomes the issue, that where decisions have to be made after they lose the capacity to make healthcare decisions. However, it is the advance directive is usually related to a terminal condition. In the alternative, a patient can appoint an agent to make healthcare decisions for him or her, and that agent can make decisions at any time whenever the patient lacks capacity. And this may be of great benefit to a patient who has mental health disorders, for example, to allow someone to stand in the shoes of the patient on a long-term sort of basis. The agent is obligated to make healthcare decisions in a manner consistent with what the patient would, using their best judgment as to what the patient's desires would be. The advance oral directive has to be, can only be made when a patient is in a terminal condition. It is kind of a last will and testament, if you will, as to what healthcare they want going forward. It has the same authority as a written directive, but it requires a little bit different witnessing, in that the attending physician must be privy to the conversation, which is hopefully a goal of any conversation about advance directives, and that there be at least 2 witnesses. Again, those witnesses may be hospital employees or family, but preferably those who will be involved in decision making going forward. Where we have a patient who has lost the capacity to make a decision, and your text talks in detail about how that determination is made, then the surrogate can make decisions for them. And again, this is not only for terminal conditions. There is a pecking order as to who can make those decisions for a patient, set forth in the statute. First and foremost, of course, is a guardian or committee that has been appointed for a patient. If they have gone through the formal process of having their being declared incompetent, then a guardian can make those decisions. In the absence of there being a guardian or an agent appointed, and the guardian or committee sits in the same position as the agent, but ahead of the spouse, and that may be somewhat concerning to a wife who suddenly discovers that Bill appointed his fishing buddy to be making health care decisions, not her. Third comes adult children of the patient, and those are all have equal standing. I was somewhat amused one time when a Catholic nun many years ago asked me whether isn't it true that the firstborn son has the priority in making healthcare decisions? Not since probably the New Testament was being written. If there's no spouse, there are no adult children, then the decision making falls to a parent who may be surviving. From there, it goes to adult brothers and sisters, and from there it goes out just as one would inherit under a will or under probate to any available relatives for the patient. There is a 7th category that has been created, the significant other, and that was intended to address the situation where often one would have a companion of many years who would probably know the patient far better, whether that was a common law sort of marriage arrangement, whether that was before same-sex marriage, or it may just be that there was a neighbor who knew Bill for the past 30 years because he lived upstairs, sort of thing. There is now a significant other sort of category when no other relatives are available. And in that scenario, the appointment of that individual must be approved by a hospital committee, and that person is still not allowed to make life support withdrawal decisions, but they can make other healthcare decisions for the patient. What the statute doesn't do is tell us some of the details of how this process works. The physician is allowed to follow the majority decision of the, let's say, adult children, which is where this usually becomes an issue, and make decisions based upon what the majority decides. It does not give us a tiebreaker mechanism that a physician can follow if you have a son and a daughter who disagree about whether or not dad should be put into hospice, or whether dad should be sent to the nursing home, or whether dad should have whole life support withdrawn. There is provision for judicial review that if there is, certainly if there is no one available to make a decision for the patient, or if you have an intractable deadlock between similar class individuals, then a judge can step in and break the tie for you. Let's talk about a durable do not resuscitate order, a DDNR, which has become more popular in the past several years for long-term care patients. It is a written physician's order. It is analogous to the traditional do not resuscitate order, but the beauty is that it travels with the patient. The problem that it was intended to address was that a physician would write a DNR order in a hospital that would not be accepted by the nursing home because the physician wasn't on staff there, or because it just wasn't written there. Likewise, a physician at a nursing home might write a do not resuscitate order, and when the patient went back to the hospital, if he was, you would not be accepted there because it was not entered into the hospital order system, or the physician wasn't on staff, or some other bureaucratic issue. When this statute came out, the Department of Health had a specific form that was required to be completed. They have now relaxed that form. You can download the form now. It used to be, it was on special paper of a special color, and they have made that a little bit easier. It travels with the patient. In fact, the Department of Health recommends that, in fact, the DDNR order be posted on a patient who's living at home, that it be posted on either their bedroom door or the refrigerator. Apparently, EMTs stop for a snack when they pick up these patients, or even over the top of a patient's bed, so that it is readily apparent to any healthcare providers that this is a patient that is not to be resuscitated. DDNR only addresses the withholding of CPR. It is not intended to be a replacement for an advance directive. It is only intended to address the resuscitation component. So let's dig a little deeper into that. A physician may issue it for his or her patient. It is not a catch-all. There has to be a valid physician-patient relationship in order for the physician to issue the order. It'd be easy for or convenient for a medical director at a nursing home to just blanket order or issue these DDNRs. If she is not the patient's physician, then that would be inappropriate. Likewise, the patient has to consent to a DDNR, or the patient surrogate decision maker, and that's someone on that list that we talked about earlier, an agent that's been appointed, a spouse, or someone else if the patient lacks capacity to make healthcare decisions. That is intended to protect the patient, as opposed, the slippery slope that is worried about in these situations is that the right to have a DDNR could become quite quickly the obligation to have a DDNR, and the goal is to avoid that scenario. How does the statute define CPR? It talks about cardiac compressions, talks about intubation and other advanced airway management. artificial ventilation, whether that is bagging the patient or putting them on a ventilator, and defibrillation and other cardiac resuscitation techniques. The distinction between the durable DNR and the traditional DNR is that the goal was not to replace the traditional DNR. That is still permitted by the statute for a physician to write for his patient in a facility. And this is the statutory section that addresses that situation. Again, it provides protection to the physician in writing these orders. It does not really tell us why there's this distinction, other than it is a matter of convenience for the physician. That if they want to write an order in the hospital chart, they don't have to get the special DDNR form to follow the patient around. There is a presumption that a DDNR is in full force and effect until it is affirmatively revoked by a patient. And a patient can revoke it simply by expressing a desire to be resuscitated. That may be by ripping up the DDNR. It may be by verbally telling someone whenever they express that to the healthcare provider, not just to Joe or Bill or somebody else passing through, but that has to be expressed to a healthcare provider. Interestingly, the statute makes provision that this is not a decision to be made in the heat of the moment. That if a patient is suffering cardiac or respiratory arrest, they can't suddenly proclaim and change their mind. Somewhat begs the question, though, there are probably a lot of patients who are talking to their healthcare providers at the time of cardiac or respiratory arrest. If a patient does revoke a DDNR, then they can reinstate it at any time that they wish. Who can follow a DDNR? And this was the part intended to again address part of the conundrum of the prior DNRs not following the patient. But EMTs and anyone licensed as a healthcare provider can follow a DDNR, even if it was issued in a different facility at a different time, a different state. It doesn't matter. The goal is to effectuate the patient's desires as much as possible. Now, the same goals can be accomplished by an advance directive. It is not necessary for a patient to execute a DDNR. However, the DDNR is probably going to be more readily available to healthcare providers who are a stranger to the patient in the emergency. An important distinction of a DDNR from an advance directive is that a DDNR cannot authorize the withholding of palliative care measures or other therapies that may be provided to a patient. The statute is written to protect healthcare providers and those who follow the patient's wishes. They are protected from criminal and civil liability in following the DDNR, and likewise they're protected from their licensure board, in that the statute specifically says that following the DDNR is not unprofessional conduct, which was an issue at one time. That immunity again follows the person who authorized the DDNR. The surrogate decision maker, if it was not the patient, is again not liable for either criminal or civil liability, and likewise not liable for the cost of treatment. There is a presumption that DDNRs were entered into willingly and voluntarily in good faith, and likewise there is a presumption that all of those who are involved in making the decision or in providing care did so in good faith. There was also a provision that enacted to protect those, whether they're a hospital intake person or a social worker or even some lay folks who are out there trying to get these patients to contemplate and enter into DDNRs. Distributing these, just as with advanced directives, is not considered the practice of law, and one won't be prosecuted for practicing law without a license. There, of course, are sanctions for willfully hiding or destroying a DDNR or an advance directive without the patient's consent, and causing the patient to live longer than expected. It's a Class 6 felony if you hide the DDNR or the advance directive. Likewise, there are criminal sanctions for hiding the fact that the patient revoked the DDNR. And that is a Class 2 felony. Let's talk a little bit about a topic that comes up from time to time, is where a physician struggles with the situation where he believes or she believes that the health care that's being requested by the patient or by, more particularly, the decision makers, the surrogates, is futile. That there is the patient is not benefiting from that care, and this often comes up in the ICU setting where the physician is of a mind that the patient is more or less deceased, but the family wants to continue the ventilator and the cardiac support and so forth. This statute provides that the physician is not obligated to continue that care. However, where the patient refuses to continue futile care, they have to make an effort to transfer the care to another physician. If the treating physician determines that his professional opinion is contrary to the advance directive or the decision maker's request, as well as the DDNR, the challenge is that this is a very difficult scenario. If you are a physician and you have determined that the care is futile, it is very difficult to transfer that to a colleague or to another hospital for additional care that you don't think is of benefit to the patient. The statute doesn't provide what happens then when you can't place a patient such as this. As you might anticipate, all throughout the United States, active euthanasia, i.e. Killing a patient, is not permitted, no matter how well-intentioned that may be, no matter what ethical plane you come from. Mercy killing is not permitted in the United States. Let's talk about a situation that comes up at the end of life quite often in palliative care, and that is the use of more pain medication than would routinely be used for a patient. The scenario that comes up quite often, for example, is that morphine is used to make a patient more comfortable and reduce their pain. The downside of that is, or upside, depending upon one's perspective, is that it decreases the respiratory drive of the patient and will hasten their death. This is referred to in ethics as the double effect, and is certainly part of Catholicism, that if the primary goal of the activity is to reduce the patient's pain, then that is morally and religiously acceptable, even if it does hasten death, which causing death is certainly not sanctioned by either the law or by Catholicism or most other religions. Virginia law allows that a patient can prescribe more than the usual doses of pain medication in the end-of-life scenario if there is intractable pain, and if the patient or if the physician certifies the medical necessity in the medical records for this larger dose of medication. It is not the pain clinic setting. It is obviously receiving a lot of scrutiny, the use of narcotics these days, and therefore a practitioner needs to be very careful about documenting the necessity for larger doses of medications and the setting of the palliative care, which is usually quite readily accepted. And moving forward to our friend marijuana, very hot topic in a lot of states these days. Virginia has straddled the fence on it for healthcare practitioners, in that Virginia law provides that a physician can prescribe cannabis, but it is still illegal to dispense cannabis in Virginia, no matter what form one takes of that, of the actual drug. Now, there are artificial similar drugs that are licensed, but not as far as prescribing as you would see in other states for medical marijuana. And that brings us to the end of our conversation about healthcare decision making at the end of life. I look forward to your thoughts as we enter into the discussion board.